Our fourth speaker is Dr. Ananda Kumar Danasekaran. Dr. Danasekaran is urology consultant and deputy head of academy in Sunwell and West Birmingham Hospital, NHS Trust in the UK, and deputy head of academy in Sunwell and West Birmingham. His topic is case study, current clinical rationale for using the Rus DD tumor stent, tip and tricks. I would like to invite Dr. Danasekaran to start your presentation. Dr. Danasekaran, over to you.
Thank you very much. Thank you for the introduction. I thoroughly enjoyed the previous three speakers. I will try my best to avoid unnecessary overlap with the previous speakers and try to see how far I can take it into the tips and tricks and the role of the Teleflex DD tumor stents. This is my disclosure. So we have already discussed quite in detail the indications for the stent, both in the malignant situations and also the normal scenarios like stone treatment, ureteroscopy, etc. The main problem with the stent is the side effects. Like for example, the stent can cause ureteric reflux, which can cause pain in the loin, and also especially in this tumor situation, we have failure of the stent because the tumor ingrowth into the ureter and also compressing the stents. Normal polyurethane stents, because of the multiple eyes throughout the stent, are much more prone to obstruction, while tumor DD stents from Teleflex is having no eyes. They have eyes only in the J component of the pelvis and the bladder. The main challenges we face when we keep a stent is overshooting, by which the stent has passed the VUJ and lower end is present in the lower ureter, or excess of stent getting crawled in the bladder, which can cause storage symptoms by irritating the trigone and the bladder mucosa. Both these problems can be circumvented by using the tumor stent because of the DD technique, which is directable and also detachable. So the tumor stents has the properties of DD coupling, which I as mentioned, directable and detachable. It has got super glide coating. This makes the placement of stent easy, and also it passes through the stricturous element easily. It is a reinforced stent. Because of that, the chances of compression is rare. I will go through the clinical benefits of the tumor stent also. So this is how the DD coupling works. The stent and the stent pusher are coupled by a mechanism, as you see here, and once the guide wire passes outside into the pusher, the DD coupling uncouples. So the surgeon has a full control on when the stent should be released. If there is a need, we can redirect the stent to the upper pole, or in case if the kidney has two pelvic calyceal systems like superior or inferior, we can direct the stent into the upper or lower pelvic calyceal system. So the surgeon will have excellent control of the lower end, and also it is directable in the upper end. I will take you through one of my patient. She is an unfortunate 55-year-old lady with lymphoma. She presented with extensive retroperitoneal lymph nodes causing obstruction of the right ureter at the level of the L5 vertebra. Here patient is lying on prone, hence the right kidney is seen as if on the left side. The antegrade nephrostomy has shown hydroureteronephrosis extending up to the L5 vertebral level. She presented with a previous stent placed in another hospital. Unfortunately, the stent is heavily encrusted and not functioning. This is the CT scan picture showing the right side hydronephrosis, both sagittal and coronal plane. This video will explain the mechanism by which the tumor stent works. So, as we all know, tumor stent comes in a package. The package consists of Guidewire, stent, and a complete assembly. It's very important that the surgeon is quite confident in the parts of the tumor stent, and he should be able to use the elements quite successfully. So we need a scope to pass the guide wire and stent. The stent has got special markings. I will discuss that further in detail. This is the DD stent with the assembly of the pusher, and we got a clamp to hold the guide wire against the patient's drape if needed. All the stents are attached with a patient card, which is quite useful when the patient needs to take the details of the stent which he had underwent. The speciality of the tumor stent is this special braided stainless steel embedded into the wall. I will go through this more in detail. As you can see, the stent shaft is made up of braided stainless steel and it is highly resistant to collapse. The inner lumen is not compressible. That's why we are getting the excellent results with the tumor stent. So this is how the DD coupling mechanism works. As soon as the guide wire is moved into the pusher, the DD coupling will get uncoupled. It comes with a pre-fit covering. This covering should not be removed till the time when we are planning to proceed the procedure. The guide wire is also quite special. It has 4 markings. The 4 markings help us to decide when we are planning to release the JJ stent. In the 4th marking, the stent will be automatically released. So as soon as we are reaching the 2nd or 3rd marking, we should be comfortable with the upper end. We should be comfortable with the bladder segment also. In this animation, you can see the kidney on the left side is blocked by the tumor. Because of that, there is hydronephrosis and urine is just trickling down and it clearly shows a blockage. So patient needs a tumor stent placement. It easily can be done by a rigid cystoscopy or a flexible cystoscopy. Here we are using flexible cystoscopy, make a good examination of the bladder to make sure there is no further recurrence in the bladder. And I prefer to use the guide wire which is coming already in the package itself. And as the guide wire is going in with the help of the image intensifier, you can easily place the guide wire in the pelvic calyceal system. The guide wire has an inner movable core, which I will discuss further in the future slides. Once the guide wire is nicely placed, you can upload the tumor stent, and once the guide wire passed the DD coupling element, the sheath can be removed. As you can see that the guide wire placement and the stent placement can be continuously monitored both optically in the bladder and also with the help of image intensifier in the kidneys. As soon as the first marking, a separate 1 marking, has reached, you can assume that the upper renal segment is going to get released. And then once we get the 4 marking segment, the bladder segment will get released. So this gives the surgeon absolute confidence in both the release of the upper kidney J segment and also the bladder J segment. Thus, I find that this tumor stent with its intelligent guide wire system with special markings help us to place the guide wire and place the tumor stent in an appropriate manner. The surgeon will have absolute control over the positioning of the stent from the starting to the end. This study is already quoted by the previous speaker. Work B has done an in vitro study comparing the Teleflex 8 French, 7 French, 6 French and also tandem stents in comparison with the stents from the other brands. It's quite clearly proven that by a big margin, the Teleflex 8 French tandem stents are much better in maintaining the stiffness, maintaining non-compressibility and the urine drainage. Now I will take you through some important tips and advantages present in this particular tumor stent. As I said, the guide wire of the tumor stent has got an inner movable core. When the movable core is nicely fit into the guide wire, the tip of the guide wire will be quite stiff and it can be used as a straight guide wire. In case if you feel that the straight guide wire is not getting into the structurous element, you can remove the inner core little bit. That makes the tip of the guide wire very flexible and malleable. This kind of modifiable guide wire you can't see in any other tumor stent or any other branded polyurethane stents. The advantage of this malleable tip is now the tip becomes almost like a J-tip guide wire. So your maneuverability into the tumorous structurous element is bit comfortable. Once you pass the structure element, you can replace the inner core back so that the tip of the guide wire will regain its strength and the tip will become more stiff. So the surgeon has full control over the stiffness of the guide wire, which you can't come across in other brands. And then the another interesting and intelligent part of this tumor stent system is the guide wire markings. The guide wire has a single mark. As I said, the single mark gives us an idea that the J segment in the kidney is going to be released, which of course you can see with your image intensifier also. Then we got the 4 marking systems, and the 4 marking systems gives us the full control on when you want to release the guide wire, when you want to make the stent decoupling, and how much of segment you want to leave it in the bladder. Less segment in the bladder, less irritation to the trigone and the bladder mucosa, patient will be comfortable. All these stents are licensed to stay for 12 months, so we don't want the patient to suffer with the stent related symptoms. Before using the DD coupling, make sure that the guide wire is passed nicely beyond the DD coupling area, because the DD coupling will be intact as long as the guide wire is inside or the outer sheath is kept intact. As a last step before you want to install the stent into the system, the assembly aid can be removed. The assembly aid just holding the DD coupling intact as long as you wish. The assembly aid is very good both in the transport and also inadvertent removal or dislodgement of the DD coupling just before you are placing the catheter. As I said, once the assembly aid is removed, you need to make sure that the guide wire is inside, otherwise the DD coupling will get disconnected. As I mentioned, the 4 markings are very intelligently placed. When you have the first marker, you can be sure that there is 3 cm to go before the DD coupling is going to get released. When there is 2 markers on the cystoscope end, there is 2 centimeters to go. And when you have the third marker, it means there is 1 centimeter to go. So when you have these markings, you can decide whether you are happy to dislodge the DD coupling or you want to maneuver it further, whether you want to have less amount of segment in the bladder or you want to direct the stent upper end into one of the calyces. So you can do all the maneuvers before the DD coupling releases itself. And once you have the 4th marking, the DD coupling will get released and you will have a successful placement of the JJ stent. So in my view, the advantage of the tumor stent is not only in the robustness of the stainless steel braided non-compressible wall of the stent and also the intelligent way by which the guide wire and the DD coupling mechanism helps us so that we can keep the stent in a very comfortable, patient-friendly manner without much of the bladder irritation. The stent is directable in case of difficult situations. As I said, if there is a bifid ureter, you can direct the stent into the upper or lower moiety as you need. It is disconnectable when appropriate. Teleflex 8 French stents kept in tandem fashion is the best available in this time for an appropriate deobstruction of the tumor obstructed ureters. There is no ice in the stent, as I said, which is very important. Presence of ice can result in the ingrowth of the tumor and create blockage. The stents are reinforced. Those who are well versed in placing the stenting, there is no specific learning curve in this DD coupling mechanism. All you need is to use the DD coupling few times to get used to that and use every aspect of the stent mechanism. Thank you very much.
Thank you, Dr. Dana Sekaran, for your great sharing. For our Q&A session, I would like to hand you over to Joanna Lim, the Senior Clinical Manager, to moderate this session. Joanna, over to you.
Thank you, Indra. Hi, everyone. I'm Joanna. And first of all, I would like to take this time to appreciate our 4 speakers for this really detailed explanation, case studies, sharing of their experience on the use of the ureteral stents in their practice. And we have, our speakers are from around the world, from the UK, from Indonesia, from Thailand, and from China. And being able to learn from their experience, their practice, their cases, gives us a bigger understanding of, these procedures. So our 4 speakers, if you could put yourselves, open your cameras, that would be great, so that we can start the Q&A session. So looking at our participants, we have a lot of participants from around the world as well, from Europe, from Asia Pacific countries. And we do have some questions for the specific doctors. So maybe let's start with the first question. And for the participants, if you have any questions at this point, feel free to type it also in the Q&A box below. You can see it on the screen. It's right below Q&A. Type in whatever questions you have. We have about 10 to 15 minutes to answer the questions that you may have. Okay, so maybe let's start with Dr. Wei. And I know Dr. Wei is still in his clinical practice. He's still attending cases. So really thank you for taking your time out to be with us at this session. So maybe we will not understand a little bit from Dr. Wei. He's from Sichuan, the China West Hospital. How many strictures or how many patients with strictures do you see every month, and how many of these cases that you see are of malignant stenosis?
There are about 30 tumor-associated strictures in the West China hospital every month. And among them, there are about 5 strictures due to compression or invasion of the ureter. And the rest were strictures due to radiations for the pelvic malignancy. And I hope this answer can solve your problem.
Thank you. And what do you think, Dr. Wei, what do you think is the ideal stents for patients with stenosis? Is there an ideal stent, in your opinion?
As we mentioned in our presentation, we think ideal ureteral stents should have the following characteristics. First, have a long enduring time. Second, ureteral stents should be easy to place. Third, we hope the stents can improve the tortuosity of the ureter.
Yes, thank you, Dr. Wei. Okay, maybe I will hand the next question over to Dr. Ananda. So Dr. Ananda, you gave us a lot of details, a lot of guidance on the decoupling feature of this tumor stents. So how do you decide on which stent to use in terms of patients with this ureteral strictures? When do you use a tumor stent, and when do you use a normal double J stent?
In a patient with ureteric stricture due to a tumor, we need to use always a specialist stent. The reason why we have to use a specialist stent is, number one, the patient needs a stent for longer than the normal duration. Say for example, after ureteroscopy and laser lithotripsy for a stone, you need to keep the stent maximum for a week or if not 2 weeks, while the patients with tumor, they are going to have the stents for months and months. So you need to have a specialized tumor stent. I'm happy with the Teleflex Rush DD coupling stent because they are licensed for 12 months. That makes the patient to have the stent change in a risk frequent manner, less need for anesthesia. As I mentioned, much more advantages of the Teleflex 8 French and 7 French stents are the DD coupling mechanism, which helps us to keep the stent in an appropriate position. I like to keep the bladder part of the stent as minimum as possible because that segment is the one which irritates the bladder and creates the storage urinary symptoms like frequency and nighttime frequency of urination. So tumor stent, especially the Teleflex 8 French or 7 French stents are very ideal, but the patients who had good capacity in the ureter, a tandem stent is a much more better choice.
What you mentioned about tandem stent, because that's the next thing I want to mention, I want to ask you about. So maybe I would ask all four physicians, but I'll start with you, Dr. Ananda. Talking about tandem stents, how often does that happen? And if that happens, is there any specific cases that you would choose a tandem stent over normal, just one stent?
Always tandem stents are slightly better in the drainage because as we know the stents drain more in the peristent area rather than through the stent. So obviously when you're keeping a tandem stent, it creates a nice H-shaped groove outside the tandem stent assembly that gives us an excellent opportunity to have a good peri-stent drainage. But placing of tandem stent is not very easy and it all depends upon the individual patient's ureter anatomy also. We may have to keep 8 French stent and then maybe in the next stent change we need to use some balloon dilators to make the patient's ureter capacity enough to have a tandem stent. If you're keeping a tandem stent, even a 6 French tandem stent is not a bad choice. So whenever a patient is subjected to have a long-term ureteric stent because of irreversible malignant situations, the gold standard is 8 French tandem stent, which is also proved by the studies which both me and Dr. VD has shown in the in vitro studies. But when it is not possible, try to go for the best possible tandem stent like 6 French or 7 French. If it's not possible, go for a single stent and plan for tandem stent on a later date.
Thanks for that. So maybe I will ask Dr. Weedy next because you also mentioned about the tandem stents in your presentation. So in your practice, in your experience, how often does that happen?
Yeah, thank you, Ms. Joanna. And I agree also with Dr. Ananda based on the evidence. The point is the tandem stent is very good compared to another stents. But we have to know that the placement is maybe difficult, and maybe if the size of the ureter is very, very small, I think at least one stent is enough. But because of the Teleflex stent, I think it's very good in the middle part of the WG stent. So it's very, they have the reinforced stents, and then the stiffness is okay, is very good. And if the passage is still good, and then we can evaluate the function of the renal is good, and then there is no hydronephrosis with the follow-up study, I think it's good for one stent. But in the beginning, if we see that maybe the ureter is a little bit large, but the patient had the tumor or the malignancy cases with the next plan is the radiation therapy, maybe they plan for another, they still have the radiation therapy for the next week or month. Maybe we have to put the tandem stents to make sure that the ureter is good for the long time. So I think that's my plan when we want to use the tandem stents.
And can the tandem stent be kept in the patient for a long time? If it is, how long would you, in your experience, have you kept it in for?
Still, we can use as long as we need that, but maybe for 1 year. Yeah, six months and until 1 year.
Great, thanks, Dr. Weedy.
Yeah.
Right, we have another question from the participants for Dr. Chawawat. Does tumor stent has any advantages for extrinsic obstruction, for example, ovarian cancer, if compared to the common double J stents?
Actually, yes, because the inside lumen has the coil inside that it actually very stronger than normal strain around 4 to 5 times.
Mm-hmm.
So I think actually for intrinsic obstruction maybe use the tumor stent, and if the failure of stent, maybe we move on tandem stem or another choice of drainage. Sometimes if fail of the internal drainage, maybe outer drainage like PCN is okay, or sometimes if we treatment about the cancer already and the cancer already subside, we can do the operation such as reimplantation or some substitute of the ureter. But normally, I think there is advantage for the tumor stent than normal stent in the intrinsic obstruction.
Great, thank you. And how do you decide which stent to use? Which size of, I'm sorry, how do you decide which size of stent to use for each procedure?
Normally in Thailand, we use 6 French of the stent, the normal stent. And for the tumor stent, we use 7 French of the tumor stent, because we only have this size, and it's easy to pass it by local anesthesia. So if we want to try the tandem stent, that egg friend with two stent inside, we need to dilate the ureter. So it's not easy to use the tandem stent, even if they can absorb the pressure, the base of absorb of the pressure. But normally we use 6 and 7 French of the tumor stent.
Okay, thank you, Dr. Chawat. So I think we have come to almost to the end of our Q&A. Maybe I would like to take this time to go through with each and every one of the presenters, just to give a summary of your discussion and also your opinion of what can be done more in the future. Maybe we'll start with Dr. Wei. It's possible that Dr. Wei has to go back to his clinical practice. So maybe Dr. Chawawat?
Maybe we need to see about case by case, because sometimes we cannot insert double J stent. So sometimes we need to see the how to drainage the upper tract, maybe PCN or double J stent or tumor stent, because sometimes we cannot use tumor stent in every case of the malignant, because sometimes it's higher cost than normal stent. We need to adjust case by case, for my opinion.
Thank you, Dr. Chawawat. Really appreciate it. Okay, how about Dr. Weedy? Any final advice that you have for our participants?
Yeah, I also agree with Dr. Chawawat. We should individualize with the case of the patient, case by case. But the message is the double G stent can be used as the short and the long term of the management of the ureteral stricture, but we should see maybe to evaluate whether the double G stent is adequate or not. And I also agree with Dr. Ananda that if the case is a tumor stent, and if the patient maybe from the cause is not, it's okay, but for the cause, but I think it's the first choice. We should use the tumor stent, and also we should use maybe the bigger is the better, but depending on the size of the ureter, because we know that the bigger size is proven to be the good, better drainage compared with the smaller size. I think that's all from me, Ms. Joanna.
Agree. Thank you so much, Dr. Weedy. Really appreciate it. And finally, over to you, Dr. Ananda.
Thank you, Joanna. My main take-home message is these patients which we are discussing are very unfortunate, and they have their own primary diagnosis of cancer, which could be like a gynecological in origin or lymphoma, like one of my patient, or primary urological cancer. So we don't want to increase the burden of the patient by putting them on a stent, which also going to produce more stent symptoms, sleepless nights, etc. So I wish the participants to learn the technique and also the advantage of the Teleflex tumor stent. Number one, it is quite robust and it is nicely braided and it is not compressible. And also try to use the DD coupling technique and also the markers in the Guidewire, which is coming in the package, so that you can give an excellent care to the patient. It gives so much of confidence to the urologist that he is able to place the Guidewire and the stent with so much of confidence. I've come across few situations where the upper ureter has got bifid pelvic calyxal system, while one calyx is not that hydronephrotic, so we wish to keep the stent on the real blocked hydronephrotic system. The directability of this tumor stent is very handy, and the detachability at the time when we need gives us the confidence that we are keeping the stent in an appropriate position. It prevents overshooting and also it prevents unnecessary too much of segment in the bladder. The time taken during the stent placement, say maybe like 15 minutes, 20 minutes in the stent placement, if it is placed appropriately, that is going to give the symptom-free life for the patient for the next 1 year. So the surgeon should keep that in mind and learn the techniques by maybe going through this video again and give an appropriate service to our patients. That's my take-home message.
Thank you, Dr. Ananda. You raised up a very good point, important point, by putting the patient in the center of what we do, keeping them in mind when we choose our procedure, choose our products that we are going to do on the procedure on them. So thank you very much for your time again. And this will conclude the end of the Q&A. I will hand the time back to Hayley to conclude the session. Thank you very much.
Thank you, everyone. Thank you, Joanna, and thank you to our guest speakers. I'd like to echo the appreciation to our guest speakers for taking time out of their really busy schedules and sharing with us all your clinical knowledge, your experience in enlightening us on such an interesting topic of management of ureteral malignancies and obstruction management. And also especially for the information you've given us with regards to how beneficial our Ruche tumour stent is too. Thank you so much to each of you. I'd like also to thank our global urology care team for supporting today's event, and also to all the team that were involved in the organisation of this webinar. They've worked really hard to make this event really successful, so thank you to that. To all of our audience from around the globe today, thank you so much for your attention and asking some really thought-provoking questions. We hope this webinar has really supported the delivery of excellent healthcare to patients with ureteral malignancies. At Teleflex, our aim is always to support the sharing of best practice and to strive for excellence. And we really hope you will join us for future educational webinars and content in 2022. I want to close this webinar today by wishing you all a very happy and healthy, prosperous New Year and Christmas. And from our Teleflex Global Urology team, thank you so much for your attention, and all of you take care, and we will hopefully see you in 2022. Thank you.
Thank you, everyone.
Thank you very much. I thoroughly enjoyed the meeting. Thank you for all the hard work.
Merry Christmas. Happy New
Thank you,
Year.
everyone.
Happy New Year
Thank
to
you,
everyone.
everyone.
Bye-bye all.
Thank you, everyone.
Thank you, everyone. Bye bye.